You increase stimulus, you get more voltage fluctuation. But in case of action potential, once action potential is done, it is done. Okay, there is no further increment, right? Even if you increase your stimulus more than the threshold, okay, say for example, threshold stimulus is around say minus 30 millivolt. So even if you increase threshold stimulus, action potential will remain same. Okay, its height will remain same. You cannot increase the height of the action potential further, right? So action potential is all or none. That means either it will happen or it will not happen. You cannot further increase or decrease the strength of the action potential. You cannot make changes in the shape of the action potential, right? It's not possible. Okay. So electrotronic potential is passive, action potential is active. Electrotronic potential is graded and action potential is all or none. That means either it will happen or it will not happen. Okay. You cannot further increase the strength of action potential. Okay. Anything else? Okay. Electrotronic potential does not require opening of critical number of voltage gated sodium channel, but action potential requires opening of critical number of sodium channels simultaneously at a time, right? Okay. Okay. Now another thing, electrotronic potential can fade away exponentially. Electrotronic potential can fade away exponentially, but action potential theoretically it can travel to the distance of infinity, right? Okay. So assume we have a neuron, we have a long neuron that connects two cities. Okay, that connects two cities from, say for example, from here to Kolkata. A long neuron. Okay, if I generate action potential here, that action potential will travel to Kolkata with same magnitude, with same height, right? Okay, I will get the same strength there in Kolkata, right? Okay, so I can take action potential to far away irrespective of its strength, right? Okay, it will not fade out. Okay, but if I take a graded potential like electrotronic potential, it will fade away gradually. So if you have a long neuron, okay, if you have a long neuron, or there are some connections of neuron, okay, connecting neurons, you are taking it to further away, right? So electrotronic potential, if you generate here, maybe it will travel to maximum this much and then it will fade away, and gradually its strength decreases in an exponential way, right? In an exponential way. You know what is exponential way? You have studied mathematics in 10+2, I guess. You know better than myself, right? So electrotronic potential fades away. So now let us see an example here in human body, right? So say for example a pinprick in my foot. Okay, a pinprick in my foot. So it is a pain sensation, right? It is a pain sensation. Okay, and our pain sensing area is here in the cerebral cortex, the somatosensory area. Okay, the somatosensory area is here in cerebral cortex. So this sensation must reach here to give me a sensation of pinprick or pain sensation, right? So the neurons that carry your pain sensation must take the signal from your foot to your brain. So this is a long distance, right? This is a long distance. So if it is electrotonic potential, maybe it will not reach my head, right? So initially the strength is this much, then this much, then this much, then this much, then it will fade away. So this is how electrotronic potential works. Okay, maybe it will travel up to my back or something like that, and then it will fade away, right? But if it is action potential, once action potential is generated in the neuron, in the most peripheral neuron where the pinprick happens, okay, that action potential will travel to my cerebral cortex and I will feel the pain, right? So action potential theoretically it can travel up to the distance of infinity. You connect neuron, synapse, you connect neuron, say for example up to US, then also action potential can travel, right? then also action potential can travel with same power, okay, with same power, with same magnitude, right, irrespective of the distance, okay, but electrotronic potential fades away. So these are the differences between action potential and electrotronic potential. This is a very important question which is frequently asked in your Viva examination. So remember the differences, at least 4 to 5 points you write under the differences between action potential and electrotronic potential. Okay. There is a separate class on the electrophysiology of the membrane where your teacher will discuss the details of electrophysiology, the role of each channel, each voltage gated channel for generating action potential. But as we are much more concerned with the cardiology, right? So we will be focusing on the cardiac action potential now, okay? Because I already said ki action potential happens in excitable cells, okay? And excitable cells are neurons. Excitable cells are all three types of muscle: the cardiac muscle, skeletal muscle, and smooth muscles, right? Action potential happens in all excitable cells. All cells are not excitable. Remember, all cells are not excitable. So now we will be much more focused on action potential of cardiac muscle cell. Okay, heart muscle ka action potential we will study now. Okay, so now forget neuron. So this type of action potential which I have drawn here, this type of action potential is a very typical of neuronal action potential. Okay, this type of action potential is very typical of neuronal action potential. And if you consider the heart separately, action potential shape, it looks different, and the ion channels are also different. Okay, ion channels are also different in heart, and particularly you need to have your concept that cardiac muscle, there are mainly two different type of tissues. One is conducting tissues, okay, one is conducting tissues. Conducting tissues means it is the specialized tissue that carry action potential. It is a specialized tissue that carry action potential from one place to another place. So conducting tissues, okay, and the remaining part is myocyte, okay, cardiac myocyte. Now, what is the difference between conduction tissues and cardiac myocytes? Conduction tissues are nothing but the cardiac myocytes itself, but specialized. In some ways, they are special. Okay. So, if I give you an example, if a cell is depolarized, okay, say for example, a cell is depolarized, it will try to depolarize all the surrounding cells. Okay. It will try to depolarize all the surrounding cell. ठीक है? एक क्लास में एक बदमाश बच्चा है, नहीं है शायद, just assume, ठीक है? So he will influence all the other students, तो सारे बदमाश हो जाएंगे, right? Okay. So this is how, if one cell is depolarized, if you are able to make one cardiac cell depolarized, all the cell will depolarized. ठीक है? इसके सराउंडिंग जो है सब डिपोलराइज हो गया, फिर ये इसके सराउंडिंग सबको डिपोलराइज कर देगा, राइट? सो ऐसे पूरा बैच बदमाश हो जाएगा, पूरा बैच डिपोलराइज हो जाएगा, राइट? ओके, सो दिस इज हाउ थिंग्स वर्क्स. सो इफ एनी कार्डियक सेल इज डिपोलराइज्ड, द होल हार्ट विल बी डिपोलराइज्ड. ओके, एंड व्हाट विल हैपन व्हेन होल हार्ट इज डिपोलराइज्ड? Contract, right? So for cardiac contraction, what needed is depolarization, right? For your ventricle is contracting, means all ventricular cells are depolarized and they are contracting. Okay? Now they are coming back from the depolarized state to further coming to resting membrane potential, which is called repolarization. Relax. Okay? So the basic thing between contraction, the basic mechanism in contraction and relaxation is just depolarization and repolarization. Okay, your ventricular cells are depolarized, contract. Your ventricular cells are repolarized, relax. Okay, your ventricular cells are depolarized, systole. Your ventricular cells are repolarized, diastole. This is how happening. Okay, so next thing is, how come one cell is depolarized and it is making all the surrounding cell depolarized? It happens by a simple thing called gap junctions. Okay. Have you heard the name gap junctions in cellular physiology, right? Okay. So gap junctions is a special structure, okay, special structure which connects two cell electrically. Okay, it connects two cell electrically. Okay, gap junction is made of connexin proteins. Connexin proteins. Okay, CONNEXIN. Okay, connexin proteins, right? So 6 connexin protein is contributed by cell A and 6 connexin protein are contributed by cell B, right? So mutually two cell together makes gap junction. It is the tunnel between two cells, and this tunnel is made by connexin protein, 6 contributed by cell 1, 6 contributed by cell 2, right? So this gap junction, it can basically pass ions, it can basically pass voltage. If one cell is depolarized, another cell must be depolarized because of the presence of gap junctions. Okay. Now assume this hall is our left ventricle. Okay. This lecture hall, assume this lecture hall is our left ventricle, and this lecture hall is made up of bricks. Okay, this lecture hall is made up of bricks, right? And all the bricks are cell, cardiac muscle cell. Now if you can depolarize one brick, all the hall will be depolarized and the hall will contract, right? Okay, why one brick will depolarize other? Because the presence of gap junctions. Okay, now cardiac muscle cells are specialized because of the presence of huge amount of gap junctions. Okay, that does not happen in all other cells, like the cell in our skin, like the cells in our kidney, like the cells in our liver. Okay, so cardiac cells are unique in that sense. These cells are having a huge number of gap junctions, right? Okay, so one brick is depolarized, all the bricks are depolarized, the hall is depolarized, the left ventricle is depolarized, and the hall will contract, left ventricle will contract, and blood will eject, okay, in the systemic circulation, right? Okay. Now, the thing is, even if there are presence of gap junctions, one brick can depolarize another brick, okay, still the velocity of flow of depolarization, मतलब the velocity of एक cell से दूसरा cell depolarize हो रहा है, मतलब depolarization wave फैल रहा है, right? Okay, so इसका एक speed है, ठीक है? The speed at which depolarization wave spreads, the speed at which depolarization wave spreads. Basically, what is traveling? Action potential from one cell to another with same magnitude. Because theoretically, I have said that action potential can travel up to a distance of infinity. Okay, if you allow, right? So one cardiac cell to another cardiac cell, action potential is traveling, or we can say depolarization wave is traveling. Okay, and it has got a speed. Okay, so God has made in such a way that still this speed, one cell to another, still this speed is slow. So we need some specialized structure to make it faster. Okay, to make it faster. So we have placed these electrical wirings, right? So theoretically, if a single brick can conduct electricity, so if I depolarize one brick, then the light should be on, but very slow, right? So we need a specialized tissues, specialized connections, these electrical wiring, which will take the electricity faster. Okay, so that electrical wiring is also there in our heart, and that electrical wiring is called the conduction tissues, right? And these conduction tissues are nothing but cardiac myocytes, which have more gap junctions in comparison to other myocytes, other cardiac myocytes, right? Okay, so the conduction tissues starts from SA node. Okay, from SA node to AV node there is a tract called internodal tract. Okay, then AV node to bundle of His, right? AV node to bundle of His. Now bundle of His at the upper part of interventricular septum, it divides into, yes, left and right bundle branch. Left and right bundle branch. Okay. Now your left ventricle is heavier, more muscular than your right ventricle. Okay. So that's why you need more electricity, you need more action potential. Muscle mass যত বেশি হবে তত action potential বেশি লাগবে to contract. ঠিক আছে? Okay. তাহলে why your left ventricular muscle mass is more than the right ventricular muscle mass? Exactly. So your left ventricular muscle mass is more than right ventricular muscle mass. Why? Because your left ventricle has to pump blood in the systemic circulation, which has got a higher resistance. Okay, and your right ventricle has to pump blood in pulmonary circulation, which is a low resistance circuit. Okay, sometimes in the course of time we will calculate the peripheral resistance in your systemic circulation, and we will also calculate the peripheral resistance in your pulmonary circulation, and we will compare. Okay, we will compare and we will see that many times higher the systemic vascular resistance is than your pulmonary circular resistance, right? Okay. So your left ventricle is pumping blood in the systemic circulation, which has got the higher resistance. So your left ventricle has to work more. Okay, simple thing. If you take 10 kg dumbbell, you get more biceps. You get 2 kg dumbbell curl, you get less biceps. Right? Simple rule. Right? So your left ventricle is working against much resistance. So that is why your left ventricular muscle mass is more. Right? Okay. Now, if I have to contract left ventricle, then I need more action potential to travel there. So one bundle branch, that is left bundle branch, is not enough. So left bundle branch will again divide into two. One is anterior fascicle to supply the anterior part of the left ventricle, and another is posterior fascicle to supply the posterior part of the left ventricle. Right? So again, to recap conduction tissues, it starts from SA node to AV node interventricular tract, from AV node bundle of His, and bundle of His divides into two: the right bundle branch block, right bundle branch, and left bundle branch at the upper part of interventricular septum, and left bundle branch it again divides into two. One is anterior fascicle, which supply means supply electricity, not blood supply, right? So supply the anterior part of the left ventricle, and the posterior fascicle, it supply the posterior part of the left ventricle, right? And one right bundle branch, it is enough to supply the whole right ventricle. Okay, so SA node, AV node, bundle of His, left bundle branch, right bundle branch, right? And it again divides into two, the anterior and the posterior, right? SA node, AV node, internodal tract, bundle of His, this is posterior fascicle, this is anterior fascicle. Okay? Okay, so now we will focus on the cardiac action potential proper. So I always tell the students that in physiology lab, in comparison to your anatomy and biochemistry, there are less things to remember. See, first of all, at the very beginning, during your introductory class or during your foundation course, I told that medical science is not for much meritorious student, because you need to memorize, आपको रटना पड़ता है बहुत सारी चीज, ठीक है, मुखस्त करते हैं, right? Okay, so the thing is difficult, but in comparison to anatomy and biochemistry, there are less to remember in physiology, right? There are less. It is mostly it is conceptual. The more you build concept, okay, the more you study, the more you will build concept. Okay, so here is something that you need to understand in physiology. Okay, but there are few points where you need to memorize things, and I will highlight that these things are to memorize at the very beginning. You need to memorize, and gradually you will be able to remember, right? Okay. So in cardiac action potential, the molecular mechanism, it will also be discussed during your classes on muscle physiology, where each muscle cell will be discussed separately. But here I will give you a brief introduction how things are happening. So once depolarization wave is traveling to a cardiac muscle cell, this L-type calcium channel opens up. Okay. This L-type calcium channel opens up, through which very little amount of calcium enters into the cardiac myocyte. So this is a cardiomyocyte, right? This is a cardiomyocyte. Depolarization wave once reaches the cardiac myocyte, L-type calcium channels opens. Okay, L-type calcium channels open, right? Now through this L-type calcium channel, calcium enters into the cell. Very little amount of calcium is required for contraction. Extracellular calcium is required for contraction of cardiac myocyte, right? Okay. Now once calcium enters into this cell, this L-type calcium channel is also here in the T-tubule. Okay. T-tubule is nothing but the invagination of the cell membrane, right? Okay, we'll study details in muscle physiology, right? Okay. So once this L-type calcium channels opens, calcium enters, and this calcium influence this specific receptor in the sarca. Okay. So this specific receptor is called ryanodine receptor. Okay, this specific receptor is called ryanodine receptor. Okay, once this ryanodine receptor is activated, more calcium efflux occurs from this sarca. Okay, smooth endoplasmic reticulum, right? So through this ryanodine receptors, more calcium enters into the cytoplasm. Now inside the cell there is huge amount of calcium. Okay, and this is responsible for a mechanism which causes contraction of the cell, right? So for cell to contract, you need high intracellular calcium. This is mandatory, right? High intracellular calcium is required for any cell to contract. So similarly, for this cardiomyocyte to contract, it need high intracellular calcium. So eta kibhabe hobe? So once depolarization wave reaches at the cell membrane, this L-type calcium channel will open, and through this L-type calcium channel, calcium will enter into the cell and it will influence the ryanodine receptor. Okay, and there is a structural change. You will study detail in muscle physiology. I am not discussing all the details over here. Okay, just the basic overview. Okay, so depolarization wave, L-type calcium channel opening, calcium enters into the cell. This calcium causes structural change in the ryanodine receptor, and there is huge efflux of calcium from the sarca into the cytoplasm. This is how intracellular calcium increases, and once intracellular calcium is high, there is contraction, right? Okay, now you see the various shape of action potential. Okay, so the shape of action potential here in SC node is this, atrial myocyte is this, AV node is this, then bundle branches, Purkinje fibers, ventricular muscle. Okay, and this is simply ECG. Okay, so these are all shapes of action potential in different parts of the heart. Okay, shapes of action potential in different parts of the heart. I'll gradually explain. Okay, mainly there are two different types of action potential in heart. One is called the fast response action potential, and another is called the slow response action potential. Okay, fast response action potential and slow response action potential. Okay. See the basic difference between two different shapes of action potential. See the ventricular muscle, the shape of the action potential is the upstroke, then there is a downstroke, but there is a plateau, right? So voltage is somehow fixed here. Okay, voltage is somehow fixed here. Then downstroke. Okay, whereas in SN node you see just upstroke and downstroke. Okay. Just compare the two action potential. One is happening in the SA node and another in the ventricular muscle. The top one and this bottom one, right? So this action potential is in the SA node where it is just a upstroke and a downstroke, right? Whereas in ventricular muscle, upstroke followed by a plateau. তাড়াতাড়ি নামছে না, কিছুটা স্টে করে যাচ্ছে ওখানে, রাইট? সো আপস্ট্রোক, দেন এ প্লেটু, দেন ডাউনস্ট্রোক, right? So these are two different types of action potential happening in heart. The action potential which is happening in the conduction tissues, okay, there is no plateau, but the action potential which is happening in the cardiac myocyte like the ventricular muscle, the atrial muscle, right, there is a plateau, okay, and we call it fast response action potential. And the action potential which is happening in SA node, AV node, bundle branch, Purkinje fibers, okay, so we call these action potential as slow response action potential. তাহলে কন্ডাকশন টিস্যুতে যে অ্যাকশন পোটেনশিয়াল হচ্ছে সেটাকে আমরা বলছি স্লো রেসপন্স অ্যাকশন पोटेंशियल, और वेंट्रिकुलर मायोसाइट, एट्रियल मायोसाइट, यहाँ पर जो एक्शन पोटेंशियल हो रहा है इसको हम लोग बोल रहे हैं फास्ट रेस्पॉन्स एक्शन पोटेंशियल. ओके, सो टू डिफरेंट टाइप्स ऑफ एक्शन पोटेंशियल्स आर सीन इन हार्ट. One is fast response action potential which happens in cardiac myocytes in atria and ventricle, and slow response action potential which happens in conducting tissues like SA node, AV node, bundle branch, Purkinje fibers. ঠিক আছে? ওকে, আচ্ছা, ইসিজি শেপে আমি এখন ডিটেল আসছি না, গ্র্যাজুয়ালি উইল ডিসকাস. ওকে, so we told the speed of action potential that is traveling to conducting tissues, right? Okay, we are concerned with the speed of action potential because speed is needed, right, to maintain our cardiac cycle, right, to maintain our heart rate. What is required is the speed of action potential. Now the speed varies. I told that conducting tissues are specialized in the sense that they have a huge number of gap junction in comparison to cardiac myocytes, right? Conducting tissues are specialized because they have a huge number of gap junctions, right? Okay, so depending on the presence of gap junction, speed will vary. Okay, so in SA node speed is 0.05 meter per second. So just see this picture. It is this picture is taken from the Ganong's Physiology, and this is a high MCQ zone, right? This is MCQ zone. That means right now you are first professional MBBS. After passing all the professional MBBS, you will be appearing for PG entrance examination, right, for MD or MS. Okay, so again it is a MCQ based evaluation, right? So one very important MCQ that comes from this slide is highest speed in conducting tissues of heart is seen in, yes, now the options will be there, right? Option will be SA node, atrial pathways, AV node, bundle of his, ventricular muscle, Purkinje system. So your answer will be Purkinje system, right? Okay, so only here you see the speed is highest, that is 4 meter per second. Okay, so remember this, very frequently we ask this in Viva examination, and also this is an important MCQ zone, right? Okay, so it is basically tells the speed at which depolarization wave traveling in the heart, or the speed at which action potential is traveling from one place to another, right? And it depends on the presence of gap junctions. The more the gap junctions, the more will be the speed of action potential. Here one thing beyond context. So let us consider neuron. In case of neuron, speed depends on, in case of cardiac myocytes, speed depends on presence of gap junctions. But in case of neuron, speed depends on myelination. Yes, very nice. Speed depends on myelination, right? You know the nodes of Ranvier, right? Myelination, then there is a break node of Ranvier, right? Okay. So neuron structure everybody knows, I guess. Okay, the structure of neuron everybody knows. You have studied in 10th or 10 plus 2, right? Okay. So in case of neuron, speed depends on myelination. The more is the myelination, the more will be the speed of action potential, right? I have given you one example of pinprick in my foot and the sensation or this action potential is traveling to my somatosensory cortex. So what do you think? The speed is high? Speed is high or speed is slow? What? Okay. So I'm giving you two examples. Okay, two examples. One is touch. Okay, someone touches my foot, and another example is there is a pinprick. Okay, which will travel faster to my somatosensory cortex? I have a sensory cortex in my parietal lobe. Okay, I have a sensory cortex, and I can feel the pinprick here, and also I can feel someone is touching my foot right here. So what sensation is traveling faster? No, touch. Yes, pain travels slow because the neurons responsible for it. Okay, because the neurons responsible for it. Touch sensation is carried by A alpha fibers. Okay, touch sensation is carried by A alpha and A beta fibers. Okay, these are huge myelinated fibers. So I will teach you neurology later on once cardiology is finished. Then we will discuss this thing. Just remember that the neurons that carry your touch sensation, that carry your vibration sensation, touch sensation, proprioception, these neurons are thick. Why thick? Because of increased myelination. And the neurons that carry your pain sensation, these are called A delta and C fibers. These fibers are less myelinated and C fibers are no myelinated. Okay, C fibers are naked fibers. They have got no myelination. Okay, so A delta and C fibers that carry your pain sensation, temperature sensation, these neurons are naked fibers. C fibers are completely naked and A delta fibers, they are having very little myelination. Okay, right? So your touch sensation, proprioception, vibration sense, this sensation, during this sensation, action potential travels faster. Okay, it seems apparently that pain sensation travels faster apparently, but actually pain sensation, during pain sensation, action potential travels slower in comparison to your touch sensation, right? Okay, anyway, forget. Don't forget, remember. Because it will be required in your nervous system classes, right? Neurology classes. Okay, coming back to your this thing, that is speed of action potential here in cardiac myocytes. It depends on presence of gap junction. So two difference here. दोनों में action potential travel हो रहा है, but in case of cardiac myocyte, it depends on the presence of gap junctions, number of gap junctions, and in case of neuron, it depends on myelination, degree of myelination. Okay, the more is the myelination, action potential will travel faster. Okay, and here is the MCQ. Remember, Purkinje system has got the highest myelination. Okay, I will everywhere I will focus the MCQs that are required for your PG entrance examination, because nowadays things are getting tougher. Okay, things are getting harder nowadays. During my time, MBBS, there were hardly 500 or 600 MBBS entry in West Bengal, right? So nowadays this number is 7,000 or 8,000. Okay, so yes, situation is really tough right now. Okay, situation is you need to compete with many students. So from the very beginning, you prepare for your PG as well, right? What I suggest, nothing, just highlight the MCQs, because in professional examination you need to write long question, short notes, explain why, right? So these are the types of the question, but at the same time you also prepare the MCQs coming from the physiology. Okay, the MCQs coming from biochemistry, MCQs coming from anatomy, right? So that will build you faster and that will build you great, right? Immediately after passing final MBBS, you will be able to write your PG entrance examination as well, right? So at the same time do that. During my class, I will focus the MCQs, the important MCQ zones frequently comes in the NEET-PG. Nowadays for you, it will be next PG, I guess. Next, the name is being changed and the exam pattern is also being changed, right? Okay, so I will focus every time the important MCQ zones. Okay. Okay, what is pacemaker? What is the endogenous pacemaker in our heart? SA node. Okay, SA node is the natural pacemaker. Okay, why it is called pacemaker? Yes, it generates rhythm. Okay, so during all my examples of generating action potential, I have given you example that someone is applying electricity to the cell and the cell is being depolarized, and once the stimulus, electrical stimulus you are applying to this cell, it is being threshold or supra threshold, then there is generation of action potential, right? But here what is happening, nobody is giving extra electricity to your heart, right? But your heart is automatically generating action potential, right? Nobody is giving extra electricity to stimulate or to get to the threshold, right? Okay, so pacemaker, the term pacemaker activity refers to the spontaneous time dependent depolarization, spontaneous time dependent depolarization of the cell membrane that leads to action potential in an otherwise quiescent cell. Okay, so this movement from resting membrane potential to threshold. Okay, because for action potential it is required to take the voltage from resting membrane potential to threshold level, it is required to generate an action potential, right? And this thing is happening automatically where? In SNO. Okay, so there is a specific interaction. Okay, so there is a specific interaction between the channels which carry positive charge into the cell and which carry negative charge into the cell, right? So there is a spontaneous interaction between these two channels, and this is why there is automatic depolarization from the resting membrane potential to threshold level. Okay, and these things are happening in SA node. Not only SA node, these things are happening also in AV node, bundle branch, Purkinje fibers, all the conduction tissues, it will happen. But basically, primarily it happens in SA node. Once SA node fails, then AV node takes its action. Okay. So once your principal is not here, some departmental HOD takes the action of principal, right? So this is how happens. Okay, if your departmental HOD is not present, someone from the professors or associate professor, they will become in charge HOD of that department. So this is how the hierarchy works. Okay, similarly, so your SA node is natural pacemaker. When SA node fails due to some reason, due to some disease, okay, due to some disease SA node fails, then your AV node takes the action. Okay, if your AV node fails, then yes, Purkinje fibers, they takes the action. Whole conduction tissues fails, atria can take the action, ventricle can take the action. We call it atrial rhythm or ventricular rhythm, right? When AV node takes the action, we call it junctional rhythm. Okay, and normal SA nodal rhythm, we call it sinus rhythm. Okay, our normal healthy heart is in sinus rhythm. That means rhythm is being generated from SA node. Okay, when the rhythm is being generated from AV node, we call it junctional rhythm. Why? Because AV node is at the junction of atria and ventricle. So we call it junctional rhythm, right? Similarly, there may be ventricular rhythm, there may be atrial rhythm, right? Okay. So the term pacemaker is an activity that refers to the spontaneous time-dependent depolarization of the cell membrane that leads to action potential in an otherwise quiescent cell. ঠিক আছে? Okay. Now pacemaker potential, rhythmically discharging cells have a membrane potential that after an impulse declines to firing level. Okay. It is called pacemaker potential. Okay. Now two fundamental reasons are there behind pacemaker activity. Two fundamental reasons. One is the interaction, which I have already mentioned, the inward depolarizing current and the hyperpolarizing membrane current. These two current, মানে যে কারেন্টটা সেল মেমব্রেনকে পজিটিভ করে দিচ্ছে, ইনসাইড পজিটিভ করে দিচ্ছে, আর যে কারেন্টটা সেল মেমব্রেনকে রেস্টোর করছে রেস্টিং মেমব্রেন পোটেনশিয়াল। ওকে, তাহলে এই দুটো কারেন্টের মধ্যে একটা ইন্টারাকশন রয়েছে, রাইট? So inward or depolarizing membrane currents interact with outward or hyperpolarizing membrane currents to establish a regular cycle of spontaneous depolarization or depolarization. Okay, so the interaction between two channels. Okay, কিছু চ্যানেলস যেগুলো আপস্ট্রোক করছে, কিছু চ্যানেলস যেগুলো ডাউনস্ট্রোক করছে অ্যাকশন পটেনশিয়াল এটা, তাই তো? তাহলে এই দুরকম চ্যানেলসের মধ্যে একটা ইন্টারাকশন রয়েছে, ওকে, যে কারণে পেসমেকার পটেনশিয়াল তৈরি হচ্ছে, রাইট? সো দিস কারেন্টস ইন্টারাক্ট ডিউরিং ফেজ 4 এ ন্যারো, আই এম কামিং, হোয়াট ইজ ফেজ 4, এই জায়গাটা বুঝতে একটু অসুবিধা হবে, রাইট? So this current interacts during phase 4 within a narrow range of diastolic potential between minus 60 and minus 40 millivolt in SA node and AV node, and between minus 90 to minus 65 millivolt in Purkinje fibers. এই জায়গাটা কি হলো? আচ্ছা, so SA node, to be very simple, SA node এর কোনো রেস্টিং মেমব্রেন পোটেনশিয়াল নেই, ঠিক আছে? আমি বললাম যে কার্ডিয়াক মায়োসাইটের রেস্টিং মেমব্রেন পোটেনশিয়াল মাইনাস 90 মিলিভোল্ট, এসএ নোডের কোনো ফিক্সড রেস্টিং মেমব্রেন পোটেনশিয়াল নেই, ইট ইজ ফ্লাকচুয়েটিং বিটুইন মাইনাস 40 অ্যান্ড মাইনাস 60 মিলিভোল্ট। ওকে, সো ফ্লাকচুয়েটিং রেস্টিং মেমব্রেন পোটেনশিয়াল মাইনাস 40 অ্যান্ড মাইনাস 60 মিলিভোল্ট। সিমিলারলি পার্কিনজি ফাইবার্স এরও কোনো রেস্টিং মেমব্রেন পোটেনশিয়াল নেই, ইট ফ্লাকচুয়েটস বিটুইন মাইনাস 90 অ্যান্ড মাইনাস 65 মিলিভোল্ট ডিউ টু দিস interaction between inward and outward current. Okay, due to this interaction between inward and outward current, SA node, AV node and Purkinje fibers, they do not have a particular resting membrane potential. In case of SA node and AV node, it fluctuates between minus 40 and minus 60 millivolt, and in case of Purkinje fibers, it fluctuates between minus 65 and 90 millivolt. Okay, clear? And this fluctuation is because of the perfect interaction between the inward current or depolarizing current and outward current or the repolarizing current. Okay, এই জায়গাটা মুখস্থ করতে হবে। So this is a fast response action potential. This is a fast response action potential. Fast response action potential কোথায় হয়? Cardiac myocyte, except conduction tissues. Conduction tissues বাদ দিয়ে atrial myocyte, cardiac myocyte or ventricular myocyte এইখানে fast response action potential হয়। And fast response action potential इसका shape कैसा है? How is the shape of action potential? How is the shape of fast response action potential? This one. Okay, so what is the basic difference between a neuronal action potential and cardiac action potential? So here is a play 2. You see, there is a play 2. So it is not just upstroke and downstroke. It is not just upstroke and downstroke. Between upstroke and downstroke, you have a phase 2. Okay, you have a phase 2, and this phase 2 is flat. Okay, so it is basically in a graph, right? So here x-axis is time and y-axis is voltage. Yes, x-axis is time and y-axis is voltage. Okay, তাহলে এই অ্যাকশন পোটেনশিয়ালটা হতে কতক্ষণ টাইম লাগছে নিচে লেখা আছে 300 মিলিসেকেন্ড। ওকে, আপস্ট্রোক শুরু হয়ে আবার ডাউনস্ট্রোক হয়ে বেস লাইনে পৌঁছাতে, অর্থাৎ রেস্টিং মেমব্রেন পোটেনশিয়ালে পৌঁছাতে, এখানে কিন্তু আমার ফিক্সড রেস্টিং মেমব্রেন পোটেনশিয়াল আছে। We have got a fixed resting membrane potential here, right? समझ रहे हो? Because it is cardiac myocyte, it is not conduction tissues, it is not SA node, AV node or Purkinje fibers. Here we have a fixed resting membrane potential, and which is minus 96 millivolt, right? So in cardiac myocyte we have a fixed resting membrane potential which is minus 96 millivolt. Okay, so upstroke start from minus 96 millivolt, it goes up to plus 52 millivolt and again come back to minus 96 millivolt. The total time duration is 300 milliseconds. The total time duration is 300 milliseconds, right? Okay. Now don't tell me why it is starting with 4, why it is not starting with 0. Okay, so it is conventional. Okay, this flat part is phase 4. Okay, so in phase 4, what current is there? Potassium current, and very specifically inward rectifier potassium current. So I'll tell here, this slide is actually for PG level, right? So potassium current is of different types. There are so many different types of potassium channels, which is not required for undergraduates. Okay, there are different types of potassium channel, like the transient outward potassium channel, slow delayed rectifier potassium channel, rapid delayed rectifier potassium channel, inward rectifier potassium channel, right? So there is a big classification of potassium channel that you don't need to know right now at first professional MBBS. So just remember, during phase 4 it is due to potassium channel, and if you want to remember, it is well. If you want to remember, and if you want to write better in your examination, you can remember. Okay, so there is no bar. So this phase 4 action potential is due to potassium current, inward potassium current, right? Now the upstroke, phase 0. Okay, upstroke is always phase 0. Okay, any action potential, upstroke is always phase 0, right? Okay, so upstroke is phase 0. It is due to voltage gated sodium channel. Okay, so sodium in, right? Upstroke. Okay, then you see there is a slight downstroke, which is phase 1. Okay, slight downstroke, phase 1, and it is due to potassium and chloride out, and specific name of the potassium channel is transient outward. You don't need to remember, still I am mentioning. Okay, so this potassium channel is transient outward potassium channel. Okay, phase 1. Then comes phase 2. So what is happening in phase 2? That means membrane voltage is fixed here. Okay, because your y-axis is voltage, x-axis is time. So in phase 2 of this action potential, voltage is fixed. Why voltage is fixed? Voltage fixed তখনই হবে যখন potassium ion ঢুকবে আবার বেরিয়ে যাবে। ঠিক আছে, কিছু positive ions are entering and some positive ions are exiting. Okay, and keeping in balance. Okay, so this is how it is happening over here. So calcium in, potassium out. Okay, so in phase 2, calcium in, potassium out. Okay, and ye dono current, calcium current and potassium current, they are balancing each other. So that is why in phase 2 there is no net voltage change. Okay, so in phase 2, calcium in, potassium out. Calcium in is due to long lasting calcium channel, and potassium out is due to slow delayed rectifier potassium channel, right? In phase 2. In phase 3, there are 3 different types of potassium channels working, and here the membrane voltage is decreasing. Right? Why membrane voltage is decreasing? Because of potassium efflux, potassium out. Okay, potassium out, and here 3 different types of potassium channels are responsible: the inward rectifier, rapid delayed rectifier, and slow delayed rectifier. Okay, 3 different types of potassium channel. Okay, for your level you can just remember potassium out. Okay, no need to explain what type of potassium channel is this, but if you write, definitely it's a good sign, right? Okay, then again comes to phase 4, right? So this is how a ventricular myocyte or atrial myocyte action potential happens, and this is called the fast response action potential. Okay, this is called the fast response action potential. Now come to the slow response action potential. Okay, so slow response action potential happens in conducting tissues, and our example will be with SA node, right? Fast response action potential happens in other cardiac myocyte, and our example was for ventricular cardiac myocyte, right? Now this slow response action potential. Okay, now this slow response action potential, that means the action potential which happens in SA node, and here lies the pacemaker activity. Okay, here lies the pacemaker activity. I told you that there is no specific resting membrane potential for SA node. Okay, it fluctuates. Okay, but to draw the action potential, we need to start from a point, right? That is minus 60 millivolt. Okay, it automatically changes to minus around minus 25 millivolt, which is the threshold, right? Okay. So you see here phase 4 is not flat. In previous action potential, phase 4 was flat, right? The fast response action potential, where phase 4 was flat. Here phase 4 is rising. Okay, matlab voltage is changing, membrane voltage is changing towards positivity, right? Okay, now there are two channels, three channels basically. There are three channels responsible for phase 4. Okay, one is long lasting calcium channel, another is transient channel, and throughout the phase 4, this red line, this green line, and this blue line, they are indicating the point where the channel flow is starting and where the current is stopping. Okay, so calcium current, long lasting calcium current starting from this point ending here, transient calcium channel starting from this point to this, and you see the F current. What is that F current? Okay, we have not mentioned this F current yet. Okay, this F current is called funny current. Funny, Funny. This F current is the funny current. Okay, and it works throughout the phase 4. You see, it is working throughout phase 4. Funny current. It is a special channel, special ion channel, which is present, again an MCQ zone. Okay, it is a special current which is present only in SA node. Okay, it is also called HCN channel, hyperpolarization gated cyclic nucleotide activated. I repeat, HCN channel, HCN, hyperpolarization gated cyclic nucleotide channel. Okay, hyperpolarization gated cyclic nucleotide channel, HCN channel. Okay, another name of this funny channel is HCN channel. Okay, funny current and HCN current are same. Funny channel and HCN channel are same, right? So hyperpolarization gated cyclic nucleotide activated, hyperpolarization gated cyclic nucleotide activated ion channel, funny current. It is a non-specific cation channel. Okay, calcium channel is for calcium, right? Sodium channel is for sodium, but funny current is a non-specific cation channel. So it can pass calcium, it can pass sodium, it can pass potassium. So it is a non-specific cation channel, right? Okay, so mostly this IF current or funny channel current, funny current, it is responsible for phase 4 diastolic depolarization. Okay, it happens during diastole. So this is why it is called diastolic depolarization. So phase 4 diastolic depolarization is mainly due to funny current, and another two current is responsible for long lasting calcium current and transient calcium current. Okay, so three current are responsible for phase 4 diastolic depolarization, which takes the membrane potential towards the threshold minus 60 to minus 30 millivolt. Okay, and it is mainly due to funny current, and other two current are responsible are ICAL and ICAT. Clear? Okay, কারোর মনে এই প্রশ্নটা আসছে এগুলো কেন জানছি, এগুলো জেনে কি হবে? Because in your second professional MBBS you will know some drugs. Okay, you will know some drugs. With those drugs we can block those channels, right? With those drugs we can block those channels, and we can change the slope of action potential, and we can change the heart rate, right? If you want to reduce the heart rate, so see, there is a particular slope of this phase 4 diastolic depolarization. Okay, a particular slope of this angle. Okay, this angle, this tan theta. Okay, this angle is important, this tan theta is important, right? So what will happen if I block this IF current by giving some drug? What will happen? This slope, it will be further flat. Okay, so right now it is this, and it will be more flat like this. Okay, then what will happen? Heart rate will fall, right? Okay, so right now it is this. So if I block the IF current, it will be this. So heart rate will fall, right? Okay, see, it is happening actually. Clear? So this one is normal. Okay, this one is normal, and the blue one is we have blocked the funny current. Okay, so you see 3 spikes here. Now you see 2 spikes within this range. Once it is blue, so heart rate has fallen down. Okay, so very frequently we need to apply this drug when we need to reduce the oxygen consumption by the heart and when we need to reduce the heart rate in a case of angina. Okay, in a case of angina, when we need to reduce heart rate and when we need to reduce oxygen consumption by the heart, we need to apply this drug to the patient, which will block this funny current. Okay, which will block this funny current and make the slope of this diastolic depolarization more flat. As a result, heart rate will fall. Okay, and patient will get relief from the chest pain. Right? Okay, now come back. Okay, so phase 4 is funny current. Phase 0 and phase 3 both are due to potassium. Okay, due to potassium is here. Okay, here, and this part is due to long last. This upstroke is due to this long lasting calcium channel. You see, it is up to this point, right? So phase 0 is due to long lasting calcium channel, and phase 3 is totally due to potassium, right? And again you have the phase 4, correct? Okay, so this funny channel is important, and the drug which I was talking about is called ivabradine. Okay, this is the drug which blocks your funny current. Okay, this is the drug. Nobody will ask you in first professional MBBS. Okay, it is a pharmacology topic, pharmacology question or medicine. So funny current or HCN channel, it can be blocked by a drug ivabradine, which will reduce the heart rate without changing the contractility of heart. Okay, heart ka contractility change nahi karega, but it will reduce. Okay, and frequently we use this drug in case of angina, where we need to reduce heart rate and reduce oxygen consumption by the heart. Okay.